Yeah, I might just get started. Okay.
Scourge of crystal meth.
The ice epidemic in Australia is now critical.
The drug known as ice has reached frightening levels.
The entire country seems to be experiencing a tragic ice age.
It's tearing the heart out of regional communities.
It's a modern-day scourge.
That Australia is in the grip of an epidemic.
The ice epidemic has hit out.
But we're told ice is rampant.
It's never far from the headlines.
Destroying lives and families.
This is a drug epidemic way beyond anything that we have seen before now.
Remember him? That was nearly 2 Prime Ministers ago. Oh my God. So it turns out we weren't having an ice epidemic, we were just having a media epidemic on this topic. And we were provided with images like this, all of those from the television. This actually is a really beautiful photo. It won a Walkley Award, but it's the headlines that are the problem really here. Monster in the ER, and we're kind of given these messages that methamphetamine users are somehow kind of evil monsters that need to be dealt with. We were told over the last couple of years that whole communities are awash with ice. 100% of people were using ice. There's a drug dealer on every corner. You couldn't go anywhere without being offered methamphetamine, and actually none of that is true. Even Sydney's awash with ice. And this is a story from Wellington, which was dubbed the South Pole because of a current affair story suggesting that 90% of their young people were on ice and they were having a really rampant problem. And then the police and the community came out later and said that, not that you would accuse the current affair of exaggerating or lying or anything, but that story was just not true. There is a problem, but it's just not the problem that we've been told it is. So you've probably seen images like this just to highlight how bad the effects of methamphetamine are. And the problem with this is that it's affected our perception as clinicians, but the community's perception of drug use more generally, and it really provides a barrier to addressing the problem effectively. This is data from NCPIC, which is sorry to anyone from NCPIC here, but I can never remember what the acronym stands for, but it's the National Cannabis Centre. They did a survey, it was a general survey about drug use. One of the questions was what proportion of the population do you think has tried methamphetamine? And the answer, so 86% of the people who answered, this is just general community, 86% of the people who answered overestimated the number of people using ice and methamphetamine, and nearly 50% said between 30 and 50% of the population had tried it. I don't know, 100% of the population have tried it. So when the figure is actually closer to 5% who've tried ice. So it's really exaggerated our perception of what the problem is. And it's even affected how the government responds to it as well. And what I'm going to talk about is what the evidence says to us and then where we should really be directing our funds. These images and the images in the media are really stigmatising to people who use drugs, and you'll see shortly that they don't all look like that by any means. And we know that when people feel stigmatised, they feel ashamed of their drug use, they won't come in for treatment, and we want them to come in for treatment if they need to. But we haven't always had this, so I'm just making a little diversion here because I find these quite amusing, but we haven't always had this perception of methamphetamine. This is a benzodrine inhaler. So this is in the 1940s, this is how amphetamines were produced. You could buy these over the counter at your local pharmacy, actually pretty much anywhere. There's a little piece of paper inside that's laced with amphetamine, and you inhale it. I haven't quite figured out whether it's like a ventolin inhaler or a nasal inhaler, but there's photos that show both. So in America, in the 1940s, about 10 million of these were sold over the counter at pharmacies. And that's at a time when the population was only about 90 million. So there was a lot of amphetamine kind of going around. And they didn't really experience a lot of problems when it was pharmaceutical grade. This, sorry to people looking on this side, but I'm going to point on this one. This is, for those of you old enough to remember, there was an airline called Pan Am, long time ago. Remember that? And this is their service menu, like, you know, when you get on Jetstar and you get to order things from the menu. And you can see here, there's here, you can get Benzodrine inhalers off the service trolley. Great. Yeah, it was marketed for, you know, pick me up on a long flight and for jet lag and, you know, all that kind of stuff. The best thing, I think, the funniest thing is that here's the alcohol, you had to pay for that, but the amphetamine was free. And it was marketed for a whole range of things. This says, Doctor, I'm tired all the time. Even the thought of beginning a day's housework makes me tired. Makes me tired too. This woman is pregnant. It's a little bit hard to see on here, but it was marketed for weight gain during pregnancy and morning sickness and general obesity and overweight. So just about anything, amphetamines could fix it. Okay, sorry, that was just an amusing diversion. Let me get to the real statistics. So this is the rate of methamphetamine in Australia over the last very long time, 15, 20 years. And you can see there's kind of a little bit there, but it's pretty flat. And currently it sits at about 2% of the population. So 2% of the population have used some kind of methamphetamine in the last 12 months. Now, at this point, people say to me, "No, that's 2013, and you know it's 2016." That maybe there's been an increase in use over that time. It's quite possible. This is from the National Drug Strategy Household Survey. The next one is being completed now, and it will be out next year, and we will see whether there's been an increase. I'm not expecting there to be a huge increase, but even if it doubled, it's still only 4% of the population. So it's still a relatively what we would call a low prevalence problem. But in addition to that, you can see these little arrows here are where we've had media epidemics in the past about ice. And you can see that there's no correlation with actual use. Okay. This is a graph of methamphetamine compared to other drugs. So it's the fourth most commonly used illicit drug in Australia, just under pharmaceuticals. Ecstasy, sorry, yes. And you can see that by comparison, ecstasy is kind of coming down, but pharmaceuticals is going up and cannabis is kind of flattened out as well. So this is pretty typical for drug use. We see little blips and trends over time, but pretty much the rate of use of drugs in the community is pretty flat, and that's pretty normal. If you have a look at So recent use, according to the National Drug Strategy Household Survey, is any use in the last year. So you might have used just once, or you might use every day. You get counted in that lot. And ever used is obviously, have you ever used in your entire life? So if you look at the difference between people who've ever used and who have recently used, you get a sense of how many new people are coming onto the market, and particularly if you look at the ever use. So ever use technically cannot go down, because once you've used, you're always going to be counted in that cohort. So, but you can see that this is flattened off between 2010 and 2013, and there might be a little kick from 2013 to 16, but pretty much what we've seen is that there's not a lot of new users coming onto the market. Okay. compared to, say, ecstasy, where we're seeing a decrease in recent users, but an increase in the number of people ever used. So this suggests that there's new users in this cohort, and compared to pharmaceuticals used for non-medical purposes, there's a huge increase. So this, although there's a slight increase in the overall population of users, it seems to be a lot of new users of pharmaceuticals. Okay, hoping that's making sense. So what that tells us is that, okay, so the rate of use in the general population has remained flat, and it doesn't seem to be driven by new users coming onto the market. This is really important for clinical policy development, and I'll tell you why in a second. So the next thing that people say to me, because no one ever believes these statistics, the next thing that people say to me is, but it's the young people. So if you just look at the whole population overall, you're not going to see the trend because it's all of these young people picking up the drug. But if you have a look at this graph, this is methamphetamine use among 20 to 29-year-olds. You can see that it's come down and flattened out. And among 14 to 19-year-olds, it's slightly gone up between 2010 and 13, but that increase isn't significant. We don't know what it's going to do after that, but all the evidence that we have from other surveys as well suggests that it's not young people picking up the drug at all. In fact, young people have, this is a worldwide trend, using less drugs generally, drinking less, having less sex, having sex later, having fewer teenage pregnancies, presumably because they're not having as much sex, and a whole range of other asocial behaviours have decreased among young people. And it's a pretty solid trend, not just in Australia, but around the world. We've raised this generation of hipster geeks. So well done to us, all of us over 40. Good work, mums and dads. But there is obviously a problem because the media, I was going to say the media just doesn't make stuff up. Maybe sometimes it does, but generally the media is responding to something in the air. The problem is that they've misdirected our attention to the wrong something in the air. If you have a look at what the types of methamphetamine available, you can see the top one there is ice, so that's the thing that's been in the media a lot. It's the crystalline form of methamphetamine, but it also comes in a powdered form, which we call speed, and a paste, which is we refer to as base. Now, the rest of Australia doesn't have much base, but Queensland is a bit unusual because there's a much higher, it's about double the amount of number of base users in Queensland than there are anywhere else. And it's probably because there's a lot of clandestine labs in Queensland, lucky you. And they, base is a kind of error in the translation of the oil to the crystal form. So as we get better at making it, not me, I do not make meth, but we, the royal we, as people get better at making meth, we see less and less base around. But because you've got about 4 times the number of labs in Queensland as the rest of Australia, some of that's a counting issue, but even so, even if it's double, it's a lot more. So you're going to see more base because not everybody's really good at making ice. Now, these drugs are all the same drug. They're not a different drug. Ice is not a different drug to speed. If you take enough speed, you will get exactly the same effects as you get from ice. It's like drinking beer or vodka. So they're both alcohol, but they're made differently in a different process. They look different, they taste different, but they have the same effect. And it's the same with speed and ice. So although ice is much more potent and causes more problems, we shouldn't separate it out from the other forms of methamphetamine because they also can cause significant problems among users. So what's happened is, and the Queensland data, this is Australian data, but Queensland data looks pretty much the same, except you've got a slightly lower rate of speed and ice use and a slightly higher rate of base use. What's happened is that between 2010 and 13, probably expect this trend to continue. There's been a sharp decrease in the number of people using speed and a decrease in the number of people using base, but a huge increase in the number of people using ice. So if we put those two bits of information together, the fact that there hasn't been an increase in the percentage of the population that uses, but there's been a huge increase in the number of people using ice, that suggests that what's happened is that people who were previously using speed have now switched to ice. So they were already using some kind of methamphetamine and now they're just using a stronger form of it. The other thing that's happened in the last few years is that the frequency's gone up, so the percentage of users who use weekly or more, and weekly or more is associated with the most problems, including dependence, has gone from 9% to about 16%. So a large number of people are using more frequently. The price has come down significantly, but more importantly, the price difference between speed and ice has become less. So that means it's much more economical to buy ice if you're going to buy some kind of methamphetamine. So it's kind of pushing, the market is pushing people towards purchasing ice rather than speed. And the purity of both speed and ice has gone up. So all of this has kind of created this perfect storm of problems. And so what we're seeing is an issue of severity of users rather than numbers of users. Now this is where everyone goes, yeah, but that's just semantics and it's still a problem. But if you think about if you had large numbers of, a large increase in users and you had a lot of new users coming onto the market and they were young people, what kinds of things would you be wanting to put your money into? That's correct, I'm reading your minds, and you are saying you would put money into drug education, prevention, probably kind of policing and border protection. But if there's an increase in the number of people who are using more dangerously and having more problems and becoming dependent on it, where would you put your dollars? You would put them into treatment, right? So this has important implications. Reading the data correctly, and we were talking just a minute ago about evidence-based policy development. Reading the data correctly, whatever we're doing around prevention and drug education, that seems to be working pretty well and we should just keep doing that. But if you're going to put more effort into an area, the data suggests that we put it into treatment, brief interventions and tertiary treatment options. So what has happened from this shift in the way people have been using is that we've seen huge increases in treatment presentations. So methamphetamine in some treatment services is now the top episode of care, whereas previously alcohol and cannabis were much more frequently seen in services. But we've also seen huge increases in hospital separations, about 300%, particularly out of mental health with people with psychosis, drug-induced psychosis. Ambulance call-outs have gone up about 25%. ED presentations, the data's not very good in emergency departments, but we've seen an increase, anecdotally seen an increase in emergency department presentations for methamphetamine problems. And we've seen some clearly documented increases in drug-induced deaths. And that's exactly what you would expect if there was an increase in severity. We would see at the tertiary end or towards the tertiary end, we would see an increase in severity. But it's not all bad news. If you have a look at these numbers, these are the percentage of people who use some kind of methamphetamine who use at different frequencies. So 70% of people use less than once a month. So most methamphetamine users use less than 12 times a year, 11 times a year or less, right? So these people, they're not going to be dependent, they're never going to go to an ATOD service. We're never going to see them at an ATOD service. They probably most likely use for a little while, a couple of years, infrequently, and then give up or go on to something else. or reduce their use. But these people are at high risk of acute harms associated with use. So while the data suggests not putting huge amounts of effort into prevention or more effort into prevention, it does suggest harm reduction is important. And primary care is a really perfect place for those kinds of interventions to be discussed, because, as I said, these people will never come into ATOD service or an acute service, but they will go to their GP and they'll be saying, I can't sleep, I have no idea why, after a weekend of using, or they might feel a little bit jittery, or they may have had some physical kind of issues related to their use. Now, there's a group of people in the middle, about 15%, who use more than once a month but less than once a week. So also they're not going to be presenting at ATOD services either. But they are going to have some more severe problems around sleep and probably anxiety. They're the people that will come to their GP and say, I feel a bit flat and depressed, or I'm feeling a bit jittery, I'm not really sure why. And this is, if we can capture this group and give them some, of existing users and give them some intervention, then we can maybe prevent them moving into this last 15%, which will be the tertiary end, which we know that once a week or more use is highly predictive of dependence and a whole range of other problems. So we want to stop people from using so regularly that they're going to become have problems, and I'll show you why in a minute, because once someone gets hooked on meth, it's really, really hard to get off, even though only a small percentage of people actually do get hooked on it. This data at the top is for ice, so it shows a shift. You can just see the shift towards more frequent use because it's stronger and it's more potent. The other thing that we know about meth users is that they're huge polydrug users. So you can see here the red is the general population of people using, and the blue is the rate of methamphetamine users using. So 10% of the population use cannabis, but 73% of the meth using population use cannabis. So, and we know that the more drugs you use together, the more problems you're going to get. Nearly all of the overdoses related to all drugs, but particularly methamphetamine, are because there's another drug on board, not because of the methamphetamine itself. So the more people mix their drugs and take multiple drugs, the more problems they're going to get into. So for this group, the bulk of methamphetamine users, harm reduction is absolutely critical, and we can do that anywhere. Wherever we come across someone who is using methamphetamine, if we ask the right questions, because they won't necessarily disclose that they're using. So harm reduction is absolutely critical. And access to early intervention is also critical to prevent that move from the 85% into the 15%. All right, I'm just going to talk a little bit about what happens in the brain to meth users and talk about the systems, the kind of service systems issues related to that. So methamphetamine increases these three main neurochemicals in the brain. So serotonin regulates our mood, I'm sure you know. Noradrenaline activates our fight or flight system, among other things. And dopamine is our reward system. So methamphetamine increasing noradrenaline means that meth users are kind of switched on all the time, and this is partly why we see a higher level of aggression among people who are using meth or using lots of methamphetamine, because they're kind of switched, their fight or flight system's switched on, and only small things will tip them over into being aggressive or angry, things that probably wouldn't bother us. But the main mechanism of action for methamphetamine is to increase the level of dopamine. And some of the estimates from neuroscience studies are 1,200% on baseline levels. So that's a lot of dopamine being released by methamphetamine, a lot. So this is what happens This is what happens when something normal, nice happens. You know, you eat a nice meal or you have sex, take other drugs. Little pockets of dopamine, those little blue things, that's not what they really look like, I don't think. They get released out of the receptors, out of the transporters to the receptors, and it gives you a little message. Let me pause that. I'm not talking fast enough today. Okay. So you get a little burst of dopamine, and it tells your brain to do it again because it feels good. Sorry. Okay. Now I can talk slower. And as that happens, this is a synapse here, this picture, and what happens is that once it gets released, it gets taken up by the other side. You can tell I'm not a neuroscientist, sorry. And it sends the message on, but the leftover dopamine kind of gets eaten up by enzymes, and then some of it gets recycled to be used again. But when meth's on board, you can see how much more dopamine gets released, but also the methamphetamine itself blocks the reuptake. So that means that dopamine can't be recycled, and eventually the dopamine stores just wear themselves out. So what happens on a weekend, you might use on a Friday and Saturday night, you use up all your dopamine, feel great, use up all your dopamine, dancing away. Sunday, you feel like shit. Monday, you're feeling a little bit better, but not that great. Tuesday, you're starting to feel a bit better. Wednesday, you're ready to go again. And that's because the dopamine stores have depleted, and they've just taken a few days to restore themselves. But what happens if you're using a couple of times a week is that process never has time to restore itself. And eventually, the dopamine receptors in the brain just say, stuff this, I'm not playing anymore, and they shut themselves down. And so it makes it much more difficult to develop dopamine, release dopamine, create dopamine in the brain. So the reason why this is important for service provision and for what we're doing is because this is a brain here, as you can see, and the red bit is the front bit, like this, and the green bit is the back of the brain, and the red bit is called the frontal lobe, and across the front of the frontal lobe is the prefrontal cortex. And if you cut the brain in half, in the middle of the brain there is the limbic system. And these two areas are really important because, as you can see, those little trees are the dopamine system. So they run directly through the prefrontal cortex and the limbic system. Now, you need the prefrontal cortex to think, any kind of thinking, decision-making, goal-setting, planning, all of those kind of higher order thinking processes. The limbic system controls our emotional and social and our memories. Now, both of those areas need dopamine to work effectively, but they also need dopamine to talk to each other. And talking to each other effectively is the way that we regulate our emotions. So normally what would happen, I know you're walking in a dark alley and a cat jumps out at you and the limbic system goes far out. Far out. And the prefrontal cortex says, don't worry, it's just a cat. Calm down, okay? So these two bits of the brain are talking to each other all the time, and this is how we keep check of our emotions and they're not going all over the place. So you can see if there's no more dopamine in the prefrontal cortex, what's going to happen? We're going to have just untethered emotional responses without any kind of thinking attached to them, okay? So this is why methamphetamine users can sometimes, particularly if they've been using for a long time, seem a bit fuzzy. They don't remember stuff, and their emotion regulation is very poor. They're very, very impulsive. Let me just flick through that. So these are the kinds of things that we're going to see in people who use meth. I don't know if any of you have ever treated someone with a meth problem. I don't know whether you've noticed that they're really bad at coming for appointments. My clients are just shockers. They'll come like late or early, or the next day, because it's really hard for them to remember that what their appointment time is and where they're meant to be, and because their head's a little bit fuzzy. But a whole range of things that we need for treatment are affected and virtually disabled among regular methamphetamine users. These impairments are bigger than for all other drugs, and in fact, they're even more severe than for Alzheimer's disease. So they're pretty serious kind of deficits that people are experiencing who are long-term meth users. The good thing and the difference with Alzheimer's is that all of those faculties are recoverable over time if they stop using. But after 6 months, the data shows that after 6 months of abstinence, their cognition's actually worse than when they were using. So it's not providing much motivation to stay off the drug. Feeling like crap and for a very long time. And there's no significant improvement in the first 9 to 12 months. So you can see here, this is a withdrawal. This isn't data, this is just my drawing. But you can see that acute alcohol and heroin withdrawal only lasts for about 5 to 7 days, but methamphetamine withdrawal lasts for about 14 days, and then there's this kind of subacute withdrawal period as well. So people are still experiencing withdrawal symptoms 2 to 3 months after they stop using. At the same time, their brains are not functioning very well, they're feeling like crap, they can't remember anything. Some of them say, God, I used to have a really good memory and now I can barely remember my name. And then even when the withdrawal's over, there's this really long readjustment period waiting for the dopamine to reset itself. And sometimes that can take 12 to 18 months. In fact, some of the research suggests that that process can take up to 3 years, and that's much worse, a much worse situation for meth users than for any other drug user. So we have to be kind of patient with meth users. There's a really high rate of relapse, as I'll show you in a minute, and we need to take account of that cognitive impairment when we interact with them. So they may be really impulsive, they may not show up for appointments, and we can, I know some services will say, 3 strikes and you're out if you don't show up, but that's not going to be really helpful for this group of people. Now, high levels of dopamine have been associated with psychosis and psychotic symptoms, and as a result of that, about 25% of people who use regularly, so at least once a month, will experience some kind of psychotic symptom, and about 80% of them will experience some kind of depression or flatness. In fact, more than half of that 80% actually meet the criteria for major depression. So mental health problems are a huge issue for methamphetamine users. And you can see here, this is data that we collected a few years ago. We just asked people who are already in treatment, so they're already kind of at the severe end, just about their using journey and their journey into treatment. And you can see that they started using at about 18, they first started using regularly at about 20, and pretty quickly, within a year, developed problems. So this is my clinical experience as well. If someone starts using regularly more than once a week, usually 2 or 3 times a week, they will start to develop problems within the first 6 to 12 months. So problems develop very quickly with meth users. And then you can see the first mental health symptoms kind of came around about the same time as the first problem use, which suggests that it's the methamphetamine that increases the risk of mental health problems, which is kind of good because it also suggests that if you stop using meth, then the mental health symptoms will go away. But it took another 2 years before they accessed treatment for mental health, and it took nearly 5 years for them to access drug treatment. So it's a long time to feel fuzzy in the head, not feel very good, have a lot of mental health problems and not do anything about it. So we really want to get people into treatment much more quickly. You can see here's an opportunity for us in around mental health. You can see if someone had no mental health treatment, it actually took them 10 years to come into treatment. So that's pretty significant, a significant time to be running around with a raging meth habit. But if you got any kind of any kind of mental health treatment, so that might have been at your GP for depression or anxiety, it might have been in a hospital, it might have been in a mental health service, it might have been a psychologist, any kind of mental health treatment, it cut the time to drug treatment by half. So there's real opportunities for early intervention. If we're thinking about early intervention for methamphetamine users, there's real opportunities through addressing mental health, rather than going straight for the jugular around trying to get them to cut down or quit methamphetamine, when that is going to be quite difficult. If we provide some good mental health treatment, they will more naturally end up in drug and alcohol treatment. So, what works in treatment? Lots of things work in treatment, and this is really, really important because I hear all the time people saying nothing works, treatment's not effective, people won't come into treatment, and it's all bollocks. People who use methamphetamine come into tertiary treatment services at exactly the rate we'd expect them to, given the population level of use and the rate of dependence. And when they get into treatment, they do really, really well in treatment. There's no specific pharmacotherapy to help with relapse prevention like there is with heroin. And we've done so many studies. There's so many medications that have been trialled, and really nothing is showing much effect at all. Unlike heroin in the 60s, when we first started doing those methadone trials, that was an absolute goer right from the beginning. So I don't think that we can rely on, that research will keep going, but we can't rely on finding a medicine to fix this problem. But it doesn't matter, because even 2 sessions of motivational interviewing and cognitive behaviour therapy significantly increases abstinence among methamphetamine users. So we do have, even a really short treatment can be very, very effective. And a whole range of other interventions, more intensive interventions, are also effective. And in fact, people find this really surprising, that there was a study done a couple of years ago looking at all drug users in treatment and their general treatment outcomes, not from any specific type of treatment. And what they found was that methamphetamine users actually have the highest success rate in treatment. So they come into treatment at about the same rate, they do very, very well in treatment, but what happens when they leave treatment, so they've stopped using and it's all good and they've gone out into the big wide world, you can see at 3 months the relapse rate's about 50%, and that's pretty normal. That is normal for all drugs. But by a year, they've about 80% of them have relapsed. And by 3 years, nearly 90% have relapsed, and they look exactly like people who've not had treatment at all. So this is data from Rebecca McKeaton's MATE study. This is looking at a resi rehab, but the data for other types of treatment look pretty much the same. So what that tells us is that people can get off meth pretty easily, but the relapse rates are very, very high. And it looks exactly the same this is the CBT and MI 2-session intervention. So we only measured at 6 months, but it's bang on the line. And this is the study that showed that they have the best outcomes in treatment, pretty much the same as well. So it doesn't matter, that tells me you can do anything with them and they get better, great, but they all relapse at the same rate, doesn't matter what you do. So we're trying to balance this idea that there are very, very effective treatments available, but huge relapse rates at the end. And that tells me that it's a drug that's a lot easier to get off than it is to stay off. So this means that the post-treatment period is really, really crucial. And I do have a point here, which I'm going to make now, that that post-treatment period is not well serviced by ATODs services. We're not funded to provide long-term ongoing support after treatment, and ATOD services do their best to do that, but usually what we do is we treat someone, they get better, we put them out in the big wide world, and we wait till they relapse, and then they can come back into our service. But in this post-treatment period, meth users don't need more treatment, they need more support. And general practice, primary care, peer workers, mental health are all fantastic places to be able to provide that support to prevent relapse. And what we want to do is to identify people early before they relapse and then get them hooked back up with alcohol and drug services at that point. And that really speaks to some of the integrated care and those kind of processes that need to be put in place. So the upshot is, I guess, that most people who use don't have problems. So there's a whole group out here that require us in primary care and acute care and tertiary services to do some prevention work, secondary prevention work and harm reduction. But when they do become dependent, it's really, really hard to get off. And so at this other end, there's a real role for us, again, in primary care and acute care, to support the ongoing relapse prevention of this group as well. So 4 really important things. Harm reduction measures are really critical. We need to provide access to early intervention, and that's being able to identify people who need assistance early, and that means you need to ask the right questions, because that 85% group are not going to disclose necessarily. But being confident that tertiary treatment works, and you can refer people into tertiary treatment and ATODs, because meth users do very well in treatment, and figuring out how we can provide that post-treatment relapse prevention through both community services and primary care. Thank you.